This conference will now be recorded.
Hello,
Yes, sir.
I am Dr. Rambabu, Professor of Surgery. So today I have to discuss some urological conditions of the kidney. Hello.
Yes,
Hello.
sir. Audible.
Already anatomy is already told by somebody else. Today I will discuss some congenital anomalies of the kidney. Okay. Congenital abnormalities of the kidney. Okay. Hello.
Yes.
Are you hearing me?
Yes.
There are certain abnormalities related to the kidney. One is the renal agencies. It may be unilateral or bilateral, horseshoe kidney, polycystic kidney, solitary kidney of the cyst, like that only. You have to discuss one by one in detail. Okay, sometimes they may ask us a short notes, 3 marks question or 5 marks question. So you should know something about these things. Okay. Now we have to first discuss about the unilateral agencies. Agencies means absent. So there is a complete absence of the kidney in the abdominal cavity. Okay. Hello. Hello. Hello.
Yes, sir.
Are you hearing me? So, first one we have to discuss about the unilateral renal agencies. Agencies means absence. So the kidney is completely absent. One kidney in abdominal cavity. So it is a genetic factor, mainly due to the autosomal dominant. Okay. So associated with the ipsilateral ureter and ipsilateral hemitrigone is missing in the bladder. So the bladder the urine flows from the kidney to the bladder by the ureter. So it may, once the kidney is absent, automatically the ureter and trigone on the same side of the bladder is also absent. Okay. So next, the remaining kidney is actually compensate the kidney functions so that it may become hypertrophied and dysplastic. The opposite kidney, normal kidney. Okay, it is more commonly seen in the males. Sometimes this absence of the kidney may associate with the other abnormalities like ipsilateral absence of the testes and vas deferens, usually absent in the males. But adrenal gland may be also be missed on the same side of the patient in the male case. Okay. Next, coming to the female, it is also there may be some absence along with the kidney absent. What are those in the female absent? Females, ovary as well as the fallopian tube. These are also associated with the absence of the along with the kidney. So next, that is the unilateral agencies of the kidney. It is a bilateral renal agencies. It is a very rare. Suppose if the two kidneys are not there, it is a incompatible life of the individual. So patient may not survive if the both kidneys are absent. Okay. Sometimes it is bilateral renal agents associated with some other diseases like pulmonary hypoplasia and fatter phases due to the oligohydramnios. It is also a congenital effects along with the absence of the kidney. That is the renal agencies. The next abnormality is the multicystic kidney. So what are these multicystic kidneys? You know, they are congenital from the renal dysplasia, which kidney is composed of various sizes of the cyst present in the stroma of the kidney, loose stroma of the kidney. If it is a bilateral, it is incompatible with the survival. So patient may not survive if the bilateral multicystic disease is present in the kidney. It is diagnosed by the mostly by ultrasound scan. If we are clinically, sometimes it may be palpable in the abdomen. The renal angle, the mass may be felt in the abdominal cavity, especially the newborn. Previously, this surgically it is removed, but nowadays nobody is removing. Okay, they may be treated conservatively. If the multicystic kidney is present in our body, we should treat conservatively. Next, ectopic kidney. So, what is meant by ectopic kidney? The other abnormality is crossed renal ectopia. This is another anomaly of the kidney. Hello? Hello?
Yes, sir.
Hello?
Yes, sir.
Okay, now we have to discuss the ectopic. Or you know what is the meaning of ectopic? Other than the normal position. So usually the kidney is arising from the pelvic region and ascends gradually upwards and reaches to the abdominal cavity and located in the lumbar region. So in ectopic kidney, it is not there. So it is present in the somewhere else. It may be either higher level than the normal position or lower level than the normal position. So it is due to the failure of this ascending process. During the ascending process, the renal pelvis is also rotates. That means it is facing, usually it is anteriorly. Once it is rotated, it will go into the medial side of the kidney. So sometimes the ectopic kidney is associated with the, some pathology of the renal pelvis. You know the renal pelvis calycis and the ureter like coming like this only. We already know about the anatomy of the kidney, isn't it? Okay. Next, the most common anomaly of the renal pelvis face anteriorly. So when the ectopic kidney is there, usually it faces anteriorly. But sometimes it may also may rotate in abnormal position in medial side of the kidney. So this is the picture showing the renal ectopia. You see, there are two ureters are there, one ureter and upper ureter. So in majority of the cases, renal ectopia, both kidneys are fused at the either upper pole or lower pole. It may occur. It is crossed ectopia. Both kidneys are fused on the same side, and one ureter. This is a one ureter, another ureter. So the one of the ureter, if it is in the crosses the midline and enters into the normal position of the bladder at the lateral aspect of the trigone, is normally. The other kidney is higher than the opening in the trigone of the lower one. This is the picture showing the crossed renal ectopia. The next second anomaly is horseshoe kidney. So commonly they can ask the short notes. You should know something about the horseshoe kidney. So it is one of the development anomaly where the complete ascending of the kidneys in the peritoneal cavity from the pelvis to the abdominal cavity and fused together either upper pole of the kidney or lower pole of the kidney. Just like horseshoe, just like a nada, group nada, like that. So the fusion, if occurs in the lower pole, is common type rather than the upper pole. You know, kidney is the bean shaped, the upper pole and lower pole. So the fusion can occur in the horseshoe kidney either upper pole or lower pole. But most commonly is the lower pole fusion is more common. Okay. Next, further these kidneys are prevented by the inferior mesenteric artery. Suppose if the fused kidneys may not go in the normal position. Why? Because it may be influenced by the mesenteric artery. So it may present only in between the abdomen and the pelvic region, horseshoe kidney. So this condition is most commonly seen in the male patients. So female to male ratio is 2:1. So the site is commonly present in the fourth lumbar vertebrae. You know the kidney extension from the 12th rib to fourth lumbar vertebrae. So usually second lumbar vertebrae, the normal location of the kidney. But in horseshoe kidney, a little bit lower. Okay, that means a fusion can occur in front of the fourth lumbar vertebrae. So that fusion part of the each kidney is known as isthmus. So that isthmus is usually lies in front of the aorta. Okay. So what are the clinical features are associated with this horseshoe kidney? So this kidney is retroperitoneally located. So it is fixed, non-mobile, and firm mass will be palpable on palpation, usually at the level of the fourth lumbar vertebrae. So when you percuss over the kidney, you may get resonant. The reason is the bowels are placed over the in front of the kidney. Suppose if you percuss in the anterior abdominal wall, so this retroperitoneal structure is covered with the bowels, so that when you percuss over that mass, you may get resonant instead of dullness. Okay. So what is the disadvantage of the horseshoe kidney? It is prone to reflux of the urine. So once the urine is collected, it may go again into from the bladder to kidney to the ureter. So it may produces the hydronephrosis or hydroureter. That is one of the problem. Next, it may produce the obstruction because of this mass is more in diameter. It may obstruct the bowels. So intestinal obstruction may likely to develop in this horseshoe kidney. Now, the another important is the stone formation. Because of stagnation of the urine, there is some sort of infection is present in the urinal solution in the urine, so that there may be some chance of development of the formation of renal stones or renal calculi or ureteric calculi or vesical calculi. So these are the complications sometimes may associate with the horseshoe kidney. So how we will diagnose this kidney? There are certain investigations to be done. So intravenous urography. When you take an intravenous urography, it looks like a flower vase. Flower vase means how it is looks like medial dilatation of the lower calyces and curving of the ureter like a flower house. Next, not only the IV view, the other investigation is the ultrasound of the abdomen. You can also find out the horseshoe-shaped kidney by doing ultrasound of the abdomen. So you see, this is the picture showing the horseshoe-shaped kidney. The lower pole is fused together. This is called the isthmus. The isthmus lies in front of the fourth vertebra and in front of the aorta. Understand? If you take IVP, you see flower has appearance like this. Okay. The other investigations also, you should do the urine analysis. You can find out any bacteria is there or not. Next, blood urea. Blood urea may be raised. Serum creatinine also to be estimated. That is also raised. Next, other investigations like the CT abdomen and CT angiogram. Why you have to take the CT angiogram? Sometimes it may also obstruct the abdominal aorta. CT angiogram and blood urea, blood sugar, and serum creatinine and urine analysis. These are the investigations to be done for when you suspect the horseshoe kidney. How we will treat this one? So whatever the complication occurs in horseshoe kidney, that should be treated accordingly. Like any urinary infection is there, antibiotics to be given. In a renal intestinal obstruction is there, open the abdomen and relieve the obstruction. And the stones formation is there, we remove the stones from the kidney, either by PCNL or nephrolithotomy or transurethral removal of the stones from the kidney or ureter. Okay, usually the fused kidney, horseshoe kidney, the fusion can occur either lower pole or upper pole, but that isthmus should not be cut down or suppression unless if you want to do any surgery related to the aortic diseases like abdominal aorta, then only you should divide the both kidneys to be separated. Then only you have to do separation of the isthmus. Unless you have to should not touch the or separate the isthmus. Okay. Hello. Hello.
Okay, sir.
Hello. So you should read
Sir.
thoroughly about the horseshoe kidney. Sometimes they may ask you short notes. That's why I stress it like anything. Okay. The next abdominal anomaly is the duplex renal pelvis or ureter. Duplex means double. Usually one in number, but in duplex the two are in number, either renal pelvis or ureter. Okay, so the duplication of the ureter or renal pelvis is a common anomaly. Similarly, horseshoe kidney, it is also common, but the incidence is only 1 in 150 births. Either duplication may be unilateral or bilateral. So unilateral duplication is the most common rather than the bilateral. Understand? Which side is more common? Left side is more common. So unilateral duplication, left side is more common than the bilateral. So usually the sexual incidence is most commonly seen in females rather than the males, whereas horseshoe kidney is commonly present in the males. Next, in the ureteric duplication, so that is a renal pelvis, that is the structure which is present in the kidney. Ureter, that means when the renal pelvis comes out of the kidney, it may act as a ureter. So the ureter duplication occurs when there are two separate ureteric buds. The ureteric buds in a congenital anomaly, genetically two buds are there, the duplication can occur. Otherwise, unilateral, normal position. So one ureter is in the normal position, other ureter in the low position. So already I had shown the previous figure like this. Double ureter. You see, this is a double ureter. So this is the one ureter, other ureter. Are fused together in the middle of the lower one third. These are two are separated. So these are normally open into the trigone of the bladder. You see, when the two ureters are there, the lower end of the each ureter are united in the lower one third of the ureter and passes down and enters into the bladder and open into the trigone of the lateral aspect of the trigone of the bladder. Suppose if the two ureters are there, this is another ureter, this is another ureter. This is the lower one, this is upper one. So here what is the mechanism? Here the lower ureter opens into the upper part of the trigone, whereas the upper ureter opens into the lower part of the trigone. That is called Wizard's Mayer law. So understand this point. The upper ureter opens into the lower part of the trigone, whereas the lower ureter opens into the upper part of the trigone. That process is known as Weigand's Mayer law. So I have discussed it, is shown very clearly seen in the picture. Okay. Usually the normal beds enters into the one side of the trigone. I already told you. So usually the bladder, when the ureter comes down and enters into the mural part of the bladder and go into the inside of the bladder and open into the trigone of the bladder and the lateral aspect. It is a non-reflex normally. If it is a double ureter, reflex will be there. The lower pole ureter is often associated with the vesico-ureteric reflex. This is most commonly seen in the infants rather than the adults. This condition is usually asymptomatic, but hello? 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 Any
Yes, sir.
doubt?
No, sir.
Tell me. Okay. What doubt you tell me, express? Usually two ureters are there. Unilateral or bilateral, isn't it? So if it is a bilateral ureter is there, upper ureter and lower ureter. The lower ureter opens into the trigone in the upper part of the trigone, whereas the lower ureter, upper ureter opens into the lower part of the trigone. That is called Weisser's-Meyer law. Usually normal ureter there is no reflex of the urine back, but when this double ureter is there, the lower pole ureter often associated with the vesico-ureter reflex, VUR, that is called vesico-ureteric reflex. That means whatever the collection of the urine in the bladder again may go into the kidney through the ureter. That may produces the hydroureter or hydronephrosis. So this condition is asymptomatic in the adult, but in the children, it is oftenly have VVR. But the VVR reflex is most commonly seen in the children rather than the adult. Okay. The swan with duplex ureter and compared with the single ureter. So this resolution is less common. That means not completely cured in case of double ureter and compared with the single ureter. So what investigations to diagnose the duplex ureter and duplex renal pelvis? So for any kind of renal diseases, first you have to do the intravenous urography or IVP, intravenous pyelography. That is the diagnostic investigation to confirm whether it is a bilateral or unilateral, duplex ureter or single ureter or single renal pelvis. Next one is the ultrasound. Ultrasound is also look for other complications like any stone formation or infection are there. Also you should do ultrasound of the abdomen. The next third important investigation is cystoscopy. There are certain scopes are there for the urology department. That is called cystoscopy, transurethral cystoscopy. So you have to pass the scope through the urethral orifice and enters into the bladder and may also look for the ureters. So the cystoscopy, if it is there, the double ureter, the ureter opening you can see on the trigone. Usually the normal ureters are lies on the lateral aspect of the upper part of the trigone in the bladder. But it may be in the double ureter, there are two openings present on the same side and other two openings are present on the other side. This different positions. So when the difference, the ureter is there, double ureter, sometimes the kidney function may be lost. So that can be assessed by the DTPA, diethylene triamino pentaesteric acid isotope scan should be done to know the function of the kidney. If the function of the kidney is damaged, you should go for nephrectomy. So these are the four investigations to be done. One is the intravenous urography, ultrasound of the abdomen, cystoscopy, and radioisotope scan like DTPA. DTPA means diethylene triamino pentaesteric acid scan. That scan to assess the renal function. You see, IVP picture. Double ureter is there. Previously, the diagrammatic representation, it is the IVP investigation. See, the two openings are there. Ureteric opening on the same side, not in the same level. So what treatment you have to give? So usually the ureter is opened in the trigone of the bladder. The opening is very small, that is called stenosis. When the ureteric stenosis is there, you should dilate the ureteric orifice. That is called ureteric myototomy. Myototomy means opening of the narrowed ureteric orifice. Not only that, you can also treat the other complications like any stone formation, infection is there. You should also treat that cause. Next, heminephrectomy. When you will do heminephrectomy, the removal of the corresponding ureter may be essential if the kidney is damaged. That is called heminephrectomy, means half of the kidney to be removed. That means the lower pole of the kidney along with the ureter. That is called heminephrectomy. In case of female, with the complete duplication, the lower ureteric orifice is ectopic, causing the urinary incontinence that can be diagnosed by the cystoscopy. So whenever there is a double ureter is there, sometimes patient may have urinary incontinence. Whenever the patient is cough or intra-abdominal rises, the urine is automatically comes out from the urethral orifice. That is called incontinence of the urine. Without the knowledge of the patient, passes the urine. So in such conditions also, you should do either ureteric implantation. So you have to dissect the ureter and it may be placed to some other area, either in the intestine, that is called ureteric ileal conduit, or you may do partial nephrectomy. Understand? When it is not functioning, you should do partial nephrectomy. When the ureter is only affected, then you should do either ureteric myototomy or ureteric reimplantation. That should be placed in some other area of the bladder or in the intestine. The other disease is ureterocele. What is ureterocele? Ureterocele is nothing but of cystic enlargement of the intramural portion of the ureter, that is due to congenital atresia of the ureteric orifice. So the ureteric orifice lies in the upper part of the lateral aspect of the trigone. So why it is developed cyst? Because of closing of that ureteric orifice. So only the intramural portion of the ureter, that means the portion which goes into the bladder, that only is dilated. That is called intramural portion of the ureter is dilated. That is called cystocele. Cele means a cyst. It contains only a mucous membrane. There is no muscular layer around the cyst because that is stretched out. Understand? So that is called ureterocele. So that is mainly due to congenital agenesis of the ureteric orifice or ureteric myostenosis. So what complications can occur in the ureterocele? So what complications? If we are not going to treat the ureterocele, what are the complications? So urinary stagnation is there, so that stone formation, recurrent urinary tract infections, and hydronephrosis. Okay. So these are the common complications like stone formation, recurrent urinary infection, and hydronephrosis. So how you will investigate the ureterocele? Again, the same investigation like intravenous phylography or intravenous urography. If you take intravenous urography, the bladder in the bladder looks like a adder head appearance or cobra head appearance. I'll show you the diagram. So this is the cobra head appearance. This is the ureteric orifice. This is the cyst. So the intramural, this is the intramural part of the bladder, the surrounding area. This is the cystic wall. Understand? On cystoscopy, it can look like. On IVP, is like a adder head or cobra head appearance. IVU reveals the left-sided ureterocele with duplex kidney. Note the characteristic of the cobra head appearance on the left side of the ureteric orifice. This is okay. So how you will treat the case? Investigation, same thing. You know, IVU or cystoscopy. The class lo mali chesta. Okay, how we will manage this ureterocele? Understand what is meant by ureterocele? It is nothing but a cyst of the ureter, where it is located only intramural part of the bladder. So that is mainly due to either ureteric congenital absence of the ureteric orifice or ureteric atresia or narrowing of the ureteric orifice in the trigone of the bladder. So how we will treat the case? So whenever there is narrowing of the ureteric orifice in the trigone, you have to do dilate. That is called ureteric myototomy. Cystoscopic. You can go through the urethra by using the cystoscope and enters into the bladder and cut down the meander stenosis of the ureter. That is called ureteric myototomy. And along with, you should remove the cyst wall. Okay, that is the treatment for the ureterocele. Sometimes we already told you it is associated with some other complications like urinary tract infections and stone formation that also should be treated. Okay, if the ureter is completely damaged, ureteric reimplantation to be needed, or you should do partial nephrectomy. So the another pathological condition related to the ureter is retrocaval ureter. Retrocaval means the inferior vena cava. You see, in the blue one is the inferior vena cava. So how it is developed, the retrocaval ureter? So it is only a developmental defect in the development of the inferior vena cava. So whenever there is a embryological defect in the development of the inferior vena cava, the retrocaval ureter can occur. So that ureter lies, you see, the ureter lies behind the ureter. So up to come this, plus they go down behind the ureter, inferior vena cava, and come again in front of the vena cava and open into the bladder. So it is due to the developmental defect of the inferior vena cava, as a result of which the right ureter passes behind the IVC or inferior vena cava and crossing the right side of the hydronephrosis and enters into the upper third of the ureter, crossing the inferior vena cava on the right side and open in the bladder itself. So if you see IVP or IVU done, it looks like a reverse J. Reverse J, that is called, normally J is the lower this one, but it is a reverse J. It is called a reverse J sign. Reverse J sign is seen in case of hydroureter. Where is the flower house sign is there? Horseshoe kidney. So what treatment you have to give? Retroviral ureter. Only Anderson Hayes operation. So what you have discussed, this is the congenital anomalies like horseshoe kidney, duplex ureter, duplex renal pelvis, and congenital cyst. The other pathological conditions you should know, some cystic disease of the kidney. So what are the cystic kidneys of the disease of the kidney? It may be polycystic kidney or a solitary cystic of the kidney. There are two types are there, genetic and non-genetic. So genetically it may be present in the one family to the other family members, and non-genetically also it may also develop some cyst in the kidney. So in the adult, the polycystic disease is autosomal dominant. That is genetical formation. In the infantile polycystic kidney is autosomal recessive. It's a very rare, but if it is there, the infant may not survive. So if infant is may die when associated with the polycystic kidney in the infants. That is autosomal recessive. Autosomal dominant is better than the autosomal recessive. So autosomal dominant is there, he can survive. Sometimes non-genetic, there is no genetic transformation. Sometimes non-genetic simple cyst may can occur, multiple cyst can occur, and medullary response kidney can occur. These are the non-genetic. Now we have to discuss the polycystic kidney, PCKD. That means polycystic disease of the kidney. It is sometimes they may ask as a short notes. Remember something regarding this one. So PCKD, that means polycystic kidney disease is a genetic disorder. It may be caused mainly due to the autosomal dominant disease, whereas in infants, autosomal recessive. So this disease is the most common in the females. Just like duplication of the ureter is more common in girls. Like that, it is also more common in females. Usually it is bilateral. Unilateral is the rare. Bilateral is more common than the unilateral polycystic kidney. What is the age incidence? Usually 30 to 40 years of the age. More common in females, 30 to 40 years of the age, and bilateral. Okay? Hello? Hello? Hello?
Yes, sir.
No one is responding. Are you listening or not?
Yes, sir.
Yes,
Ah.
sir.
So polycystic kidney, sometimes they ask as a short notes. You should read thoroughly. Okay. So polycystic kidney is bilateral, not a unilateral. One side it is present earlier than the other side. Usually the two kidneys are not occurring the same time. One is occurs first and subsequently occurs in the other side of the kidney. So this is the macroscopic appearance of the kidney, polycystic kidney. So number of cysts are there. A small variable size of the kidney is present in the outer surface of the both kidneys. Is one kidney, the other kidney. Similarly, if you take the CT scan, they can also see. You see, there are gas shadows. Are you able to see? So this is one kidney, this is another kidney. This is a polycystic kidney of the adult. So these polycystic kidneys sometimes may be associated with the other pathological conditions of the body. What are the other polycystic kidneys can occur? Polycystic kidneys means more than two cysts are present in the particular disease is called polycystic. So it may present in the associated with the liver, multiple cysts in the liver, multiple cysts in the pancreas, multiple cysts in the lungs. So these are commonly associated. So whenever if you find out polycystic kidney by IVP or CT scan, you can also look for pancreas, lungs and liver also you should examine thoroughly. Sometimes it may associate with the perianeurysm at the base of the skull. You know, circle of Willis is present at the base of the skull. These vessels also may be aneurysm. Aneurysm means there is a communication between the fusiform dilatation of the vessels. That is called perianeurysm, present at the base of the skull. That is called circle of Willis. Sometimes it may also associate with the valvular disease of the heart, especially mitral prolapse. Patient may have a MR. Mitral prolapse is there. Patient may have a mitral regurgitation. So these are the other diseases associated with the polycystic kidney. Okay, one is the liver, pancreas, lungs, and base of the skull like berry aneurysm and mitral valve collapse. So how the cyst can occur in the polycystic kidney? So the cyst can occur usually the junction between the tubule and the collecting duct. From there, the cyst has been developed. Gradually, the other cyst also developed in the same condition in between the distal tubule and collecting duct. See, cystic formation occurs at the junction of the distal tubule and the collecting tubule. Suppose if you rupture the clear fluid cyst, it contains a clear fluid. Sometimes it may contain the brownish colored fluid. That brownish colored fluid due to the rupture of the vessel in the cyst itself. It may produce the hemorrhage. So the brown color is due to the hemorrhage or the collection of blood in the fluid cyst itself. So what are the clinical features of this disease? One is the kidney, the mass is palpable in the lumbar region or in the renal angle. So bilateral palpable renal mass is one of the clinical finding. Another is patient may have a pain in the loin or back region, the lumbar region, and patient may have hematuria. Why hematuria is developed? Due to the rupture of the cyst may produce hematuria. And infection, because of immunity has less, patient may susceptible to get such infections. Next, renal hypertension. The renal hypertension can occur associated with the polycystic kidney. Next, increase the urea, blood urea, uremia. That is, normally it is 45 milligrams per dl, but it may go up to the 65 to 70. So what are the investigations? So ultrasound is the standard investigation to know the presence of cyst present on the surface of the kidney or not. Next, IVP or intravenous urography. Here, if you take a picture of IVP, you can see spider-leg pattern. How the spider-leg leg pattern can occur due to the compression of the renal pelvis, elongated and compression of the renal pelvis, and narrow of the stretched calyces. So the calyces are narrowed and renal pelvis is compressed, just like the spider. Spider means salipurbu. Looks like that. Spider leg pattern can be seen in IVP examination. Next, blood urea and blood serum creatinine are raised. The urine specific gravity become low. Normally 10-20, it may be go into the 10-15 or 10-10 like that. So what are the other diseases mimics like a polycystic kidney? One is the renal cell carcinoma. Renal cell carcinoma also present, you can palpate the mass in the renal angle or in the lumbar region. Next, hydronephrosis. So hydronephrosis is due to any ureteric obstruction, ureteric stone can cause the hydronephrosis, renal agenesis, ureteric agenesis, ureteric atresia. These are all produces the hydronephrosis. So hydronephrosis can also mimic the features of the polycystic kidney. And only solitary enlarged renal cyst. Solitary renal enlarged cyst. Sometimes it may also, we think it of huge solitary renal cyst can also produce the polycystic kidney appearance. So what is the treatment you have to give? Usually should not go for immediate surgery, you should wait and watch. But if the problem is there, then you should go ahead with the surgery. What surgery you have to do? Here you have to do when the patient is having a loin pain, continuous pain is there in the loin, or there is a hematuria, or certain infections are there, surgical intervention is required. What surgical intervention should be done? Roving's operation. Sometimes they may ask you what is Roving's operation. It is nothing but to open the cyst and let out all the fluid which is present in the kidney, cystic of the kidney, cyst of the kidney. Then the edges are marsupialized, just like a iodide cyst. The cut edges should be marsupialized. That means you have to suture. What is the cut edge is there left over, that should be sutured with the base of the cystic cyst of the base of the cyst. Should be continuous sutures to be done. That is called marsupialization. So that is the standard gold standard treatment for the Roving's operation. Sometimes without opening of the opening method, ultrasound guided aspiration also could be done, but it is there is a chance of refilling of the cyst. So that better to do Roving's operation. Okay. Roving's operation, sometimes they ask in the orals. What is Roving operation? It can be done in the polycystic kidney. The cyst is opened and let out all the fluid. The remaining part of the cystic wall is excised and the cystic wall is marsupialized. That is called Roving's operation. Not only the open method, but also it can be done by the laparoscopic method or retroperitoneoscopic aspiration is there. Once the renal failure sets in, that means the both kidneys are spoiled. If both kidneys are spoiled, you should do bilateral nephrectomy and followed by the renal implantation, transplantation. Otherwise, patient may not survive. So once the both kidneys are removed, the alternative thing is followed by the renal transplantation, bilateral renal transplantation or unilateral renal transplantation. One kidney has to be worked out. So that is the ultimate treatment when the renal failure has developed in polycystic kidney. Okay, understand? Then
Yes, sir.
the last one is the solitary cyst of the renal system. Now we have discussed about the polycystic kidney. Now means the one is so many cysts are there. Here, solitary renal system, that means only a single cyst is there. It is only acquired but not a congenital. You remember, polycystic kidney is autosomal dominant. It may be a congenital, but it is not a congenital solitary cyst. Okay, how this solitary cyst has developed? What is the pathogenesis for the development of solitary cyst? That is resulting in the infection of the blockage of the tubule leading to the cystic formation. When the tubule of the kidney is blocked out, some collection may occur in the cyst, may produce this solitary cyst. Usually unilateral and present as a mass, just like this one. The outer surface is smooth and tender if the hemorrhagic is there. This is the solitary cystic of the kidney. This is a CT scan. This is a pathological image. Treatment: when the kidney is exposed and the cyst is aspirated and portion of the cystic wall is removed, that is called Kirwin's operation. That is Roving's operation, Kirwin's operation. Here, what you have to do, that is a marsupialization is done, but here the cavity is filled with the perinephric fat. Kirwin's operation. Occasionally, the cyst may present in the one pole. You may do nephrectomy, partial nephrectomy, either upper pole or lower pole. Lower partial nephrectomy or upper partial nephrectomy should be done. Okay. The next class we can discuss the remaining things. Okay. Thank you. Hello. Hello.
Thank you, sir.
Thank
Okay.
you,
Next
sir.
class we'll discuss another diseases. Okay. Babu Rajesh.